Should we start, Ayrton?
Yes, yes. So, good afternoon, good evening, and it's a pleasure to have this lecture. And my name is Ayrton Stein. I'm a professor of Federal University of Health Science of Porto Alegre. And during this week, we are having a full-time course on healthcare, health economics assessment in healthcare. And it's being promoted by uh, this Federal University of Health Science of Porto Alegre in liaison with the Bridge University from Amsterdam in the Netherlands. And it's a pleasure to have this open session. In this course, there are around 30 participants, MSc and PhD students from our university, and also health professionals and professors from all over the country. And we would like to thank very much Health Technology Assessment from the Ministry of Health that is being supporting this course as well. And of course, we would like to thank very much the professors from Bridge University that are very supportive during this week. And tonight, we're going to have the lecture that will be addressed by Judith Bosman. She is professor of the Department of Health Science of the Faculty of Health Science, and she's also the coordinator of this department. So thank you, Judith, and welcome everyone for this open session.
Thank you, Ayrton. It's a pleasure to be here. And I see some familiar faces as well. Alina I saw and Luis. So very nice seeing you again. So I suggest we get started. We have, I hope, an interesting program for you. Yeah, for us it's tonight, but for you it's still the afternoon. So the topic for today is the use of economic evaluations in decision making. And I thought it would be nice to bring some of my colleagues to also present to you. So I will start with an introduction into economic evaluations. Then my colleague Johanna van Dongen or Hanneke van Dongen will follow with an example of an economic evaluation that has been used in actual decision making. And then Mohammed El Alili will present the decision maker's perspective. And Mohammed was one of the PhDs at our department over the past 4.5 years. And now that he finished, he started working at the Dutch Healthcare Institute. So he's actually in the seat of the decision maker now instead of in the seat of the researcher. So I will start with a brief introduction into economic evaluations. Ayrton already introduced me. I'm a full professor in methodology of health technology assessment at the Department of Health Science, and that's part of the Vrije Universiteit in Amsterdam. And we do research, of course, but teaching is also a big part of our responsibility. So we teach at both the bachelor, master, and postgraduate level on health technology assessment. So let's start with why cost effectiveness research is important. So I think this applies to every country in the Western world and increasingly also in developing countries, that we have limited resources available for healthcare. The technological possibilities are increasing every day. So we have to think hard, how are we going to spend these scarce resources and make sure that we spend them wisely. So cost effectiveness aims to inform that kinds of decisions, and the focus or the aim of using cost effectiveness information in decision making is that we want to maximize health outcomes within the budget that we have available. And an economic evaluation is defined as a comparison of the costs and effects of 2 or more interventions. And it's very important to realize that it's not about identifying the cheapest intervention, but about identifying the intervention that gives value for money. So we want to know if we need to invest more money in the new intervention than we would have in the standard care, the care that is standard now, that this is weighed up, that this is balanced by an increase in health effects, so that we obtain additional health effects for the additional investment that we need to make. So it's not about identifying the least expensive option. So in an economic evaluation, we often perform economic evaluations alongside randomized controlled trials. So in a randomized controlled trial, we select a study population, we perform the randomization, one of the groups gets the intervention, the other group gets the control treatment. We follow up participants over time, and at the end of the follow-up, we measure outcomes. And in a standard RCT, you only measure clinical outcomes. However, an RCT is a time-intensive type of research. It's also expensive to conduct an RCT. So if you're doing an RCT, then it's a small additional effort to also collect cost outcomes. So when you want to evaluate also cost effectiveness, you do not only collect clinical outcomes, but also cost outcomes. So how much care do patients use? Do they use informal care? Are they absent from their paid job? All these kinds of costs you also take into account. So there are different types of economic evaluations, and I always try to use the term economic evaluation when I'm talking about cost effectiveness studies in general, and use the term cost effectiveness analysis when I'm talking about an economic evaluation in which effects are expressed in disease-specific outcomes. So examples of disease-specific outcomes are insulin levels, the severity of depressive symptoms, the severity of pain, all kinds of outcomes that are being used by healthcare professionals to tailor the management of the patient. So based on these disease-specific outcomes, healthcare professionals may change the treatment regime that a patient gets, or maybe even stop the treatment. So these disease-specific outcomes are very useful for healthcare professionals. However, the limitation of using such disease-specific outcomes is that it's only possible to compare between interventions that target the same disease-specific outcome. So if you're looking at an intervention for depression and an intervention for diabetes, then if you look at disease-specific outcomes, you're comparing apples and oranges, because for diabetes, the insulin levels are important, but for the depression intervention, the severity of the depressive symptoms is important. So you cannot compare the cost effectiveness of these treatments against each other. Whereas if you're a decision maker, you may need to make a choice between this new intervention for diabetes or that new intervention for depression. So you cannot admit both interventions into the healthcare insurance package, and you have to make a choice. But if you have that different disease-specific outcomes, then there's no way to compare them. So generally in economic evaluations, we prefer to measure health effects in quality-adjusted life years. And quality-adjusted life years are the number of life years adjusted for quality of life. So one QALY is equal to 1 year of life in full health. And the nice thing about these QALYs is that they are the same, they should be the same, whether you calculate a QALY in depression or in diabetes or in high blood pressure. A QALY is a QALY is a QALY. And one QALY is always equal to 1 year in perfect health. So this QALY, the quality adjusted life years, are calculated by multiplying utility, which is a comprehensive index score for quality of life, and you multiply that by time. This utility value is anchored at 0, which means that you're dead, and at 1, which is perfect health. Negative values, however, are also possible, and a negative value indicates that the patient is in a health state that is considered so bad that being dead would be the better option. So these negative values indicate that there are very severe decrements in quality of life, and that these are so severe that death may be the preferred option. So how do we measure these utilities? Well, generally in a randomized controlled trial, we assess quality of life, and this is the EQ5D 5-level version. You have to believe me on that because I don't think you can read this. But we assess quality of life with such an outcome measure. We ask patients or participants to fill out that questionnaire, and then we use a kind of tariff to convert these health states to utility values. So that's the way we generally estimate utility values in a randomized controlled trial setting. There are different quality of life instruments available to estimate utilities. The most widely used are the EQ5D 3-level or 5-level version, or the SF6D. And if you compare these two, then from research, it becomes clear that the EQ5D has a ceiling effect. So the EQ5D doesn't make or doesn't really well make distinctions between people in a relatively good quality of life, whereas the SF6D doesn't distinguish well between people who have a relatively low quality of life. So depending on the severity of the disorder that you are doing a study in, you may want to go for either the Eurocall or the SF6D. One thing to keep in mind when choosing one of these quality of life instruments is that with the Eurocall questionnaire, there are many different tariffs available. So there's a Dutch tariff, there's a UK tariff, the Japanese tariff, a Portuguese tariff. There are, for many different countries, there are tariffs available, whereas for the SF6D, only a UK tariff exists. And Angela Jornada Ben has showed in one of her recent papers that there may be a difference between the different tariffs, so that there are cultural aspects that influence how people value their quality of life. So using a tariff that is specific for your country may have advantages over using a UK tariff. So quality of life is one thing, so that's the effect side of the equation, but we also need to measure costs. And which costs you take into account depend on the setting. So in the Netherlands, we have or the recommendation is to use the societal perspective in any economic evaluation that is being used for decision making. And this societal perspective means that you do not only include healthcare costs, but also patient and family costs, like informal care provided by neighbors or family members, lost productivity costs. So if you're unable to go to work, or if you're less productive than you would normally be at work, and costs in other sectors. So in case of children with an autism disorder, special schooling may be a cost category that fits into the category costs in other sectors. So in the Netherlands, we take this societal perspective. However, in many other countries like the UK, but also Brazil, you only take into account healthcare costs. And then we say that the economic evaluation is performed from a healthcare perspective. But which perspective you choose is always dependent on the setting in which you want to make allocation decisions. So when we measure costs, we always want to measure how many resources the participants in our trial actually use. So we want to know how many times participants visited their general practitioner, how many days they were admitted to the hospital, etc. And when measuring these healthcare utilization rates, it's always important to think about the condition that you are looking at. So which items are important. And in some situations, if you're looking at people with appendicitis, then probably visits to a psychologist are not very relevant. But if you're looking at people with depression, then probably you want to focus most on mental health care service use. But you also want to really think about how often you measure, how often you assess these healthcare utilization questionnaires, and what the optimal recall period is. So for relatively young people, a recall period of 6 months may work pretty fine, but for older people, 3 months may be the maximum recall period. So you really have to think about the study population to identify healthcare utilization types that you want to measure, and how often and with which recall period you measure healthcare utilization. Then the next step is to calculate costs. And then we have to attach a price tag to the healthcare utilization rates that we measured. And we use a concept called opportunity costs when calculating costs in economic evaluations. And that means that we try to estimate the benefits that are foregone by using our resources for this type of healthcare instead of using it for something else. And Luis Correra explained that very well in one of the classes this week. So he said, instead of sitting in at course today, I could also clean my house. And the benefits that are foregone by sitting in the house, sitting in the course, is a clean house. And in economic evaluations, we try to approximate these opportunity costs by calculating the actual resources used when you produce 1 unit of healthcare utilization. So when we look at a GP visit, you would take into account the salary costs of the GP, but also the costs of housing, the costs of having an assistant in the GP practice, etc. And in that way, we try to approach the actual costs of producing such a unit of healthcare. When we have collected both outcome and cost data, we combine these in what we call the incremental cost effectiveness ratio. So in this incremental cost effectiveness ratio, we calculate the difference in costs between the intervention and control groups, and we divide that by the differences in effects between the two groups. And then we may end up with 4 different scenarios. So in the green part of the this is a cost effectiveness plane where we plot the difference in effects on the x-axis and the difference in costs on the y-axis. And the green quadrant of the plane indicates that our new intervention is dominant over the old intervention, over usual care. So the new intervention is less expensive and more effective than the old intervention. If the opposite is true, so the new intervention is more expensive and less effective than the usual care treatment, then we say that our intervention is dominated by the usual care. So it's not a good option to implement. In these situations, the green and the red, the decision is pretty clear, right? Either the intervention is beneficial in both aspects, costs and effects, or it's it's worse than the control treatment with regard to both costs and effects. In the other 2 scenarios, where in the blue quadrants, you have to make a trade-off. So in the upper right quadrant, the new intervention is more expensive and more effective, and you have to make a decision. Am I willing to spend additional money to gain additional health effects? Whereas in the bottom left quadrant, the trade-off is, are we willing to lose some health effects while we are also saving money? So in these situations, you need to make a trade-off. What we often do is that we plot our ICER in the cost effectiveness plane. So in this case, I have an ICER with an incremental cost of 2,200 euros and an additional QALY gain of 0.05 QALYs. So this results in an ICER that's situated here. And if you calculate the ICER, you end up with an ICER of 44,000 euros per QALY. So in this case, we need to invest 44,000 euros to gain 1 QALY. You can also show uncertainty surrounding this ICER. So here is the black dot indicating the point estimate of the ICER, and the gray dots around it, the gray circles around it, represent the uncertainty surrounding this ICER. And you can see by the fact that most of these gray dots are located in this northeast quadrant, that in this case we are pretty sure that the new intervention is more expensive and more effective than the usual care. So the next question is, how can we decide whether this new intervention is cost effective compared to usual care? If this new intervention is more expensive and more effective than usual care, how can we decide whether this new intervention is cost effective? Well, we generally do that by comparing this ICER with some kind of ceiling ratio, and it's often called lambda. And if the ICER is smaller than the ceiling ratio, so if it's lying below this line indicating the ceiling ratio, then we consider the new intervention cost effective compared to usual care. The problem, however, is that we are not very sure about the value of this ceiling ratio. So this ceiling ratio actually means that we are saying we're willing to pay at max 50,000 euros or 30,000 euros per QALY. But we actually, in reality, we do not know for sure how much money we are willing to pay to gain 1 QALY. And as a result, or as a consequence of that, the concept of cost effectiveness acceptability curves was developed. So you can see that I plot the same ICER as we saw before, the same point estimate of the ICER we saw before. And again, the gray dots surrounding the point estimate indicate the uncertainty. But now I created also different ceiling ratios. So this ceiling ratio of 3,000 euros per life year gained indicates that our maximum willingness to pay to gain 1 life year is 3,000 euros. And you can see that there are not so many gray dots below this ceiling ratio. So at ceiling ratio of 3,000 euros per life year gained, we're not very confident that our new treatment is cost effective compared to usual care. And actually the probability, so the proportion of gray dots between the line indicating 3,000 euros per life years gained is 0.225. What you see is that as you increase the ceiling ratio, that there are more and more dots lying below the line indicating the ceiling ratio. So as our ceiling ratio increases, the probability of cost effectiveness also increases. And actually at a ceiling ratio of 7,000 euros per life year gained, this is around 0.64. And the maximum probability of cost effectiveness is 0.96. And you can plot these probabilities in a figure that we call a cost effectiveness acceptability curve. So on the y-axis, the probability that my new treatment is cost effective compared to usual care is shown. And on the x-axis, the ceiling ratio is plotted. So you can see here that with increasing ceiling ratios, the probability of cost effectiveness increases, and at some point after 20,000 euros per life years gained, it remains relatively stable. So in this way, we can combine statistical uncertainty, which is expressed by the probability of cost effectiveness, with our decision uncertainty about the value of the ceiling ratio. So for decision makers, this graph in the end is the most informative for the decision that they need to make whether the new intervention is going to be reimbursed or not. So when you're doing an economic evaluation, it's always very important to keep in mind that the ultimate aim of your economic evaluation is to inform decision makers. So what you want is that your economic evaluation resembles actual clinical practice as much as possible. And that has some consequences for the design of your randomized control trial. So if you also want to estimate cost effectiveness in a randomized control trial, then you need to make sure that the population that is included in your trial is representative for the actual patient population. So do not use too many inclusion-exclusion criteria, like what's often the case in efficacy trials, that people with comorbidity are excluded from participation. But these are the people that, as a family physician or a cardiologist, you most often see in your clinical practice, right? That are patients who have risk factors like smoking or comorbid disorders like hypertension. So you want to make sure that these patients are also included in your patient population. The next thing is that you have to be careful that you compare the new intervention with usual care, because that's the situation on which decision makers have to decide. Am I going to replace usual care as it is now with this new intervention? So their decision problem is focused around usual care and not some kind of other new intervention. So always include a usual care arm as well. And finally, it's very important that you avoid research-related tests and procedures. So do not draw additional blood for research purposes, no additional x-rays, because they artificially inflate the costs in the treatment groups. But it's also possible that you detect abnormalities that you would otherwise not have detected. So they may have gone away naturally, or they may have become worse, at which stage you would have identified them. So you want to avoid these research-related tests and procedures, because they can both affect your effectiveness and the costs of your new intervention. Okay, so then this is a crash course in economic evaluation theory. So it's time to, I think, to apply this theory to actual clinical practice. And that's where Hanneke will take over from me.
Okay, thank you, Judith. Judith, you're also in charge of going to the next slide. So if I do this, then please press thanks. Okay, so my name is Hanneke van Dongen. Also Johanna Maria van Dongen, because that's my actual name. So that's also the name you'll find on my publications. But I'm an assistant professor of health technology assessment, also at the Department of Health Sciences at the Vrije Universiteit in Amsterdam. And during this presentation, I will give an example of how economic evaluation evidence, or evidence that's generated in economic evaluations, is currently being used in the Dutch healthcare system. Okay, so prior to, talking about how it's used, I think it's good to give you some background about how the Dutch healthcare system works. In the Dutch healthcare system, we have a thing called a basic health insurance package. That's a health insurance package that costs around €100 per month. And it's mandated for all Dutch individuals. So we're obliged to have such a package, and insurers are not allowed to not accept us if we are applying for a package at their insurance company. Because €100 is for some people quite a high amount of money. People with low incomes in the Netherlands are compensated. They receive a monthly compensation, and kids are up until the age of 18 are free, so they do not need to pay insurance. Okay, the package is highly regulated. It is regulated by the Minister of Health, Welfare and Sports in the Netherlands. So he or she eventually decides what treatments are covered or reimbursed through the mandated basic health insurance package. And in doing so, or in making these decisions, the Minister of Health, Welfare and Sports is advised by the Dutch Healthcare Institute. And then the question is, what is covered? Included in the basic health care package, this is in Dutch, but hopefully the icons are clear. The GP is covered because in the Netherlands, the GP is the gatekeeper to all healthcare services. Most in-hospital services, so as for example, the care of physicians is covered. Many pharmaceuticals, especially the more expensive ones, are covered. Midwives are covered, or gynecologists, as well as short mental health care services, and also emergency department visits. Care like this is all covered. In addition, we also have something called additional packages, and those are not mandated, and insurers are allowed to to reject us. So for example, you can buy additional packages for certain services. I, for example, have an additional dentistry package. But in order to get such a package at various insurers, you need to send in a photo of your teeth in order to get accepted. So that's where selection of can take place. So in a nutshell, that's the system. And up until an X number of years ago, cost effectiveness didn't play a role in such decisions. However, in 2012, a new Dutch funding model was implemented, which in Dutch is called voorwaardelijke toelating. And voorwaardelijke toelating means that while decisions about the inclusion of certain treatments are still pending, so the inclusion of those treatments in the basic health insurance package, research is funded and conducted to guide such a decision. The first project that was actually funded through this new reimbursement model was the MINT study. The MINT study was conducted by researchers from our department as well as other hospitals in the Netherlands. But Esther Maas, you see a picture of her on this slide. She was actually one of the lead authors and lead researchers in this project, and I merely helped her with the effectiveness as well as the cost effectiveness analysis. But the aim of this project was to assess whether radio frequency denervation is cost effective and or effective compared to usual care for treating chronic low back pain patients. And I'm not an expert in radio frequency denervation, not at all. So I actually wrote down what it is. It's a treatment that uses radio waves to create heat and destroy a part of a specific nerve. In this procedure, the medial branch of the nerval spine carrying the pain signals is destroyed in order to try to relieve the patient's pain. And as you can see on the right photograph, it's quite an intrusive procedure. And it's, it is oftentimes applied under local anesthetics, but it is quite intrusive. Okay, so Esther, together with another PhD student, she conducted this study in which all patients that received radio frequency denervation during this reimbursement model funding scheme was while this was happening, all patients who wanted to receive the treatment also needed to participate in the study, either in the randomized controlled trials, and if they would not want to participate in the randomized controlled trials, they would at least or should at least complete an X number of questionnaires. And the effectiveness results of this trial have been published in the JAMA. And I will first briefly discuss those results, and then I will talk about the cost effectiveness results. This is the flow chart of individuals in the study. So lots of potential participants were were recruited or were identified, of which a large number eventually decided not to participate in the randomized controlled trials, but they did participate in the observational study. And then an X number of patients did participate in the randomized controlled trials, in which radiofrequency denervation was compared to usual care. And here there are 3 randomized controlled trials, and that's due to the fact that they developed or conducted separate randomized controlled trials for separate kinds of joints. So there was a trial for the facet joint, there was a trial for the I'm not good at pronouncing this, sarcoiliac joint, and a combination trial. So then pain could originate from either one of those, from both of those joints. Okay, these are the results. There's lots of information on this this slide, but Judith, if you could press, 3 times. Yes, thank you. I think the most important message here, here are the results, the pain intensity results. Pain intensity was the primary outcome of the trial. So for all trials in this case, and as you can see, a minimally clinically important difference or improvement in pain is defined as a 2-point difference. And as you can see here, all of those differences are way smaller and non-statistically significant, or at least the majority of them, at all measurement points and during the complete follow-up period. And the overall effects also did not reach a minimally clinically important difference at all. So based on those results, the researchers concluded that it was not effective compared to usual care. Well, of course, they also wanted to assess the cost effectiveness of radiofrequency denervation. So we also performed economic evaluations alongside the trials. And the results of those trials have been published in Value in Health. Well, again, lots of information on those slides, but I think the take-home message here is that for the facet joint and the SE joint trial, costs were higher in the radiofrequency denervation group compared to the usual care group. And for the combination trial, costs were actually lower for the radiofrequency denervation group, but the level of uncertainty, so the 95% confidence interval shows it, was very big. So the confidence interval was very, very wide. Could you press, yeah. This is, again, a table with lots of information, but here I'd like you to look at the figures that are inside the green square, because those are the differences that were found in health-related quality of life. And then for all of the 3 trials, and then per trial, the highest number is the outcome of the main analysis. And for all of the trials, they also conducted various sensitivity analysis in which they slightly made some changes in order to assess whether those changes, for example, with respect to the instrument that they used for estimating quality adjusted life years, whether that impacted the results of those trials. And as you can see, in all cases, except for one sensitivity analysis for the combination trial, the health-related quality of life of radiofrequency denervation patients was lower as compared to the health-related quality of life of usual care patients. Well, therefore, they also plotted those cost effectiveness acceptability curves that Judith just discussed. Those indicate the probability of the intervention actually being cost effective compared to its comparator for various values of willingness to pay. Well, here you can see that it doesn't matter how much we're willing to pay per quality adjusted life years. The probability of radio frequency denervation being cost effective is very, very low. For the combination trial, that probability was a little bit higher, but still it did not become higher than 0.65, 0.67. So we, in all cases, consider these to be low probabilities of cost effectiveness. So based on this, we concluded, and the Ministry of Health, Welfare and Sports, as advised by the National Healthcare Institute, concluded that radio frequency denervation is not effective, neither cost effective for treating chronic low back pain. And as of January 1st, 2016, it is decided that radio frequency denervation is not funded anymore through the basic health insurance package in the Netherlands. Patients could still receive this treatment, but that means that they should pay for it themselves. Well, of course, it has also stirred lots of discussion. So as you can see, various commentaries and discussion papers have been published already. This one is a nice one. Could you go back one? Yes, the title is very nice as well. Flawed study design and incorrect presentation of data negatively impact potentially useful intervention treatment for patients with low back pain. A critical review of JAMA's MINT study. So yeah, it seems that some researchers do not agree with the conclusion of the MINT study papers. Okay, well, this is it. I think this study was the first time that economic evaluation had a huge impact on the healthcare decision making. But Mohammed probably can tell you way more about it because he works at the Dutch Healthcare Institute.
Yes, I can. Let me share my screen. I think this should be it. Can someone nod when you see my presentation? And if I make it bigger? Perfect. Well, Hanneke and Judith briefly introduced me at the beginning of this session. I work at the Dutch HTA authority as a pharmacoeconomic advisor, but I also work as a researcher at the Department of Health Sciences at VU Amsterdam. To kick off this little part of the presentation for today, I would like to ask you a question. I don't expect you to answer this question, but I guess many of us already have done something like this in the past, including me. So did you ever buy a product that doesn't work? So for instance, this gym form total abs that's making your abs look like Arnold Schwarzenegger, but you know, it's too good to be true. Or it's the same with you know, these advertisements on the television with a super knife that stays sharp, or a sponge that cleans all the stains. It's all fake. But imagine a situation where someone else is getting this product and you pay for it. That's weird, right? You're buying something that doesn't work for someone else. Well, and that's where the National Healthcare Institute comes in. It tries to avoid this disappointment in the execution of healthcare. So we only want to have good and effective care that is proven to be effective in our health insurance package, as Hanneke briefly introduced to you what the health insurance package is and what it consists of. So that also comes back in the slogan of the Healthcare Institute, that we don't want to reimburse, or we want to have good care that is no more and no less than necessary. But how does the National Healthcare Institute come to such conclusions? So the health insurance package, just to recap very briefly, every citizen pays a fee to be insured and to be able to get care without paying for it themselves. And it means that there is a large fund, a large big pile of money that needs to be allocated as efficiently as possible to actually treatments or interventions or medications that are working, that are effective. That brings us to our first package criterion, which is effectiveness. In a sense, it means it is a knockout criterion. If an intervention or a medication is not effective, it means no other step or no other criterion is important anymore because the medication doesn't work. Then there are three other additional steps or three other additional criterions: necessity, cost effectiveness, and feasibility. And in cost effectiveness, that's where economic evaluations actually come into play. But to make it more understandable, we have a graph here that actually summarizes the reimbursement procedure in the Netherlands. First of all, we have the knockout criterion: effective, yes or no. If it's not effective, the advice of the National Healthcare Institute is to not reimburse the intervention. The next step is necessity. Are there any patients that are really in need of this new treatment? So it means that if the disease is has a large impact on quality of life and is very intense, patients might benefit from an innovative new treatment. Then the next step comes into play, which is cost effectiveness. So something might be effective, but it needs to be offered at a reasonable price, at an acceptable price. And that's where the costs and effects are related. And if it's cost effective, obviously it will be included in the health insurance package. And if it's not, it will not. But mind that cost effectiveness as a criterion is not set in stone. In some cases, even when an intervention is not cost effective, there might be still some substantial reasons why it still should be part of the package. Imagine a situation where only 5 or maybe 10 patients have the disease. The intervention is not cost effective whatsoever, but because our Dutch healthcare system is based on solidarity, we still want to not to exclude care for those type of patients. And because it's only 5 patients, perhaps the budget impact is not very, very high. And let's dig into the cost effectiveness part that I have shown you before. In this case, we also have 4 steps that we need to take when we get economic evaluations. So in this seat that I'm sitting now, I'm not performing the economic evaluations, but I'm getting the economic evaluations from the manufacturers of medical technology or from pharmaceutical companies making the drugs. The first step that we take is to look whether the analysis that they have offered us is methodologically sound. If that's not the case, we often send back the analysis and ask them for more advanced analysis and so on and so forth. If that's all right and we can work with the analysis that we have got, we look at the incremental cost effectiveness ratio. We look at the cost effectiveness results, and we try to decide whether the intervention can be considered cost effective or not cost effective compared to its alternative. And that's based also on solidarity. So Judith briefly told you that it is difficult to determine the reference value or the ceiling ratio, the willingness to pay, the lambda. In the Netherlands, we have a method for it, which is based on the proportional shortfall method. And it means that we are willing to pay a little bit more for patients who are in worse health. So burden of disease means actually the severity of disease. The more severe the disease, the more the Dutch government is willing to pay to reimburse the intervention. And it ranges from 20,000 euros per quality all the way up to 80,000 per quality. And it's calculated by the formula that we see here above. We take the remaining qualities without the disease minus the remaining qualities with the disease, and we divide it by the remaining qualities without the disease, and that gives us the proportion. And if it falls within one of those 3 ranges, we choose the corresponding willingness to pay rate, willingness to pay value, and then we check whether the ICER is below that value or above that value. Then we obviously have said it's cost effective or not cost effective, but we have forgotten to talk about the uncertainty. Uncertainty is typically illustrated in CE planes and cost effectiveness accessibility curves, as you have seen twice in Judith's presentation and Hanneke's presentation. So we can decide whether it's a risk to invest or to reimburse a certain intervention. The last step is, would more research be useful, and is it possible? This is especially important if the ICER is around the threshold, so around the willingness to pay value, the reference value. If there is lots of uncertainty, it means that in some situations it might not be cost effective anymore, or vice versa. But if we know that the ICER, the point estimate, is very far away from the threshold or very far below the threshold, perhaps extra research and more research is not necessary. And in these 4 steps, we are guided by a scientific advisory board consisting of different experts in the field of clinical fields, physicians, medical specialists, but also statisticians and experts in health economics that actually back our decisions or back our advice to the government about the cost effectiveness or whether or not to reimburse a certain intervention. But this is still not the last step. As I said before, cost effectiveness is not set in stone. So it doesn't mean that if something is not cost effective, it's not going to get reimbursed. So the last, very, very last step is the societal appraisal. And again, the intervention or medication does not get to this phase if it's not effective. The knockout criterion effectiveness is very important. So in the last step, there is a public debate by the Insured Package Advisory Committee, which consists of different types of people, from psychologists to philosophers to economists, that actually try to, from their own point of view, think about the societal impact, think about the ethical consequences, think about economical consequences. So for instance, maybe a very harsh observation, but is it useful or is it cost effective to invest a lot of money for people who are almost dying? I mean, it's not good to say, but that's the types of questions that are actually being discussed in these types of discussions. And eventually, advices are coming out of this debate, and it can take very weird directions. Recently, I had a submission in which the intervention was cost effective, but because there was too much uncertainty, so the results were based on a phase 2 trial, they advised to negotiate prices with the manufacturer. So they say, Minister of Health, we want you to negotiate with the manufacturer to decrease the price because this is uncertain. And as soon as we have more data, then we are going to give them the full price. In some situations, also when it's not cost effective, it's too expensive, but still reimburse it because there is an urgent need. There is no other option for the patients, and we still need to reimburse this medication. Otherwise, they don't have anything left. In this case, a negotiation can take place between the Ministry of Health and the pharmaceutical company, but also perhaps some kind of regulations in which patients do co-payments and pay a little part of the medication or intervention themselves. So just to remember, cost effectiveness is a very important tool that helps us to relate costs and effects together, and but it's not set in stone. But again, it is a very important lead in order also into the negotiations of prices, because if we have a large probability of cost effectiveness, the manufacturer could always say, no, it's cost effective, I'm not going to decrease my price. But if you can play with these numbers and try to figure out an optimal price, it always helps negotiation and eventually to maximize the health of the population as a whole. Thank you very much. I think I'm just in time, 20:59. Yeah.
Thank you. So can we have some questions? Judith, is it possible?
Yes, sure.
People, and I forgot when I introduced to thank especially Angela, who was the link between Bridge University and UFCSPA, and she had worked in our university some time ago, and now as she is a researcher at Bridge University, she made the connections. And I'm sure she's been very helpful in this course during this week as well, especially in the practice in the afternoon. So thank you, Angela. I'm sure everyone who is taking the course agrees with me.
Thank you, Ayrton. I think Luis Correa raised a hand as well.
Yes, thank you very much for the 3 lectures. I was, they were great. And I liked very much the example of the denervation for low back pain. Because I see this thing very frequently also in Brazil. So Mohammed said there is a knockout criterion that, first of all, there needs to be an effectiveness. Then we think about cost effectiveness. But this example of Henneke that demonstrated to us, there was no effectiveness. So my question is, why to do a cost effectiveness study in this situation, and why?
Yeah, that's a very good question, and that's a question we get asked more frequently. I think it's also mainly related to the fact that the study design was determined before we knew the results. So the study design included both an effectiveness as well as a cost effectiveness analysis. So, and in accordance with this study design, we also decided to perform everything and to publish everything. Also, because there are also lots of systematic reviews for the Dutch Healthcare Institute, they did eventually indicate that their decision was already based on the lack of effectiveness. Based on the lack of effectiveness, they already decided to push it out of the basic health insurance package. But from a scientific standpoint, we did decide to move forward also with publishing the trial-based economic evaluation results, because we were also afraid that if systematic reviews, for example, will get published or conducted on radio nerve denervation, and we would not publish ours, that would bias the results of such reviews. So that for us was one of the main reasons to do that. And eventually, I think for Value in Health, which is a quite relatively high impact journal in the field of HTA, health technology assessment, they also wanted to publish this paper because they liked the fact that this was the first example of this reimbursement scheme. So that's also why how we framed the paper. So we explained the context and the role that it played in the decision-making process.
So I think it has a lot of value, scientifically speaking. So I agree with the publication and all. The thing is, for a decision maker, sometimes when people put and present this cost-effective analysis, according to my experience, the decision shift to cost effectiveness if people don't quite analyze the quality of the evidence for efficacy or things like this.
Yeah. No, and therefore I really like the scheme of the Dutch Healthcare Institute that they use, the one that Mohammed presented, is that first and foremost, it should be effective. And then we look at the rest, but there are escape routes. Something might be, well, a little bit not ineffective, but it saves lots and lots amounts of money. Yeah, then it might might also be something that you would consider. But I truly like the emphasis that is placed on effectiveness in our Dutch healthcare system. I think Evelyn, yeah.
Yeah, I wish Mohammed could explain to us what as proportion is that you have about medications or drugs And which is the proportions of decisions you ascertain by year regarding medical devices or implants or equipments?
So if I understand correctly, you're asking whether what is the difference, or like the distribution of drugs versus medical technology and so on and so
Yep.
forth. Well, these type of interventions are less common than drugs. I mean, drugs are coming. I cannot give you an exact number because I only worked there for 8 or 9 months, but I guess it's around, let's say, 80% drugs, and the rest are robotical things, special treatments, interventions, behavioral treatments. But the most of the time, it's always drugs.
Okay, and the flow of the work and choices you made there, it's generic. Do you have specifics for drugs separated from implants and equipments?
Yes, I haven't talked about it in the presentation, but the type of economic evaluation we receive for both might be very, very different, because for drugs, typically we receive model-based economic evaluations. Obviously, they have to go through the same system, but for trial-based economic evaluations, sometimes they use another type of evaluation that doesn't take so much how can I say it, intensity as going through a model. So it's based on systematic reviews, a trial-based economic evaluation, and then based on that, we only write a simple letter to the minister to say it's cost-effective, yes or no, because it's based on empirical data. But for the model-based, the drugs, we have more, it's a standard procedure, as I have explained in the lecture.
Do you have many registries ongoing that you can count on to ascertain the useful life of an implant, for instance, to plan the healthcare system?
Could you repeat the question?
Longitudinal studies in implants or equipments where you can count on to plan the replacement, the re-interventions, and the length that will stay with such an implant, for instance, or you need to renew medical equipment, useful life. This is the concept or total life cycle that we are trying to implement.
Yeah, I understand what you're saying now. It's about what time does it take before a new medical technology needs to be replacing the old one. Well, the Healthcare Institute doesn't by itself say when it should be replaced. I mean, it's based on the information from the manufacturer and so on and so forth, science. And eventually, if something new comes by and is more effective and is better and can stay for a longer time, the Healthcare Institute is going to take a look at it and determine whether it should be part of the health insurance package.
Yeah, and Mo, I think she was also wondering whether you have large databases, for example, to fill those models validly.
Yes, but it's observational data, and it's not randomized data. It's claims data, health insurance data from 17 million citizens of the Netherlands. So it does have some statistical complexities that need to be accounted for. But there is some data, a public available data is, for instance, it's called the GIP data bank, and it registers all the users of certain medications in the Netherlands. So you can search for instance, metformin, which is for diabetes. You can search for each year how many people have been using this, and then you can use that type of data for your budget impact analysis or for your model.
And this is aggregated data? which is made public, or you have conditions to follow the patient through the time? So in order to ascertain if they have more complications, less complication, more requirements on emergency visits or other resources.
If we talk about the data bank I have used as an example, that's aggregated data, but the claims data typically is per year or per time period, so it's longitudinally. Yeah.
And you can follow a patient through the time.
Yes.
Through the length.
Yes. Yeah.
Ayrton?
Okay, thanks.
Yes, well, it might be for you, Judith, this question. Do you communicate economic issues of resource allocation for lay people in the Netherlands, and how lay people participate on the decision-making process?
Yes, so Mohammed talked about the final phase in the assessment procedure, the open plenary meeting, and their patient advocates are also present, so they can also speak in at these meetings. And in the Netherlands, it's a topic that regularly appears in the newspapers as well. And generally, when there's a very expensive drug that has been turned down, then there's a lot of then there are a lot of publications in the newspapers. And I think, I mean, if it's your father or your mother, of course you want him or her to have the medication, right? But I think that the public opinion is realizing more and more that we need to make these choices to be able to, fulfill the demand for care that there is in the Netherlands.
Thank you.
Luis? Or was it still?
I'd like to follow up on this Evelyn question regarding observational data. So we know that randomized clinical trials are the gold standard for efficacy. But when you talk about effectiveness, we want more of the real world. So, I mean, even if it doesn't work because of confounding, it means it doesn't work in the real world. Okay, people are not better.
Yeah.
So, despite of the confounding, shouldn't we consider observational data? I mean, well quality observational data, a kind of the gold standard for effectiveness and cost effectiveness? I know it's
I
provocative.
think they should complement each other, but I totally agree with you. And we're currently also running a project at the department where we develop methods to do economic evaluations using that type of observational data. So I think if we want to really fully inform decision makers, then that kinds of data should also be available for them.
The study that Henneke presented had the two branches, randomized and observational. Did the results come near?
Yeah, it's nice that you asked that question, because that Esther Maas, she actually her PhD thesis was built around this trial, and we also I was also involved in that paper, but it was her ID, and she's also the lead author. But she also compared the results of the trials with those of the observational study. And those results are actually published in the Journal of Clinical Epidemiology. And those results showed that the trajectory of the pain scores were similar in both groups. So that the intervention groups as well as the observational cohort patients had the same progression of their pain scores.
Nice. Very good. Thanks.
Thank you.
So are there any other questions? That's where.
I wish just to have the Mohammed contacts, if it's possible, in the Moodle too, so we could ask more details about the institution. We cooperate with Conitec here in Brazil, so we do a lot of those assessments for internal demands from the Health Secretariat of São Paulo State, and also from the Ministry of Health themselves. They send demands. For instance, do you have a site in English? Is this URL that you've quoted there the address to go? I don't know if you can help us. Sometimes we write also some regulatory embasements for the National Agency for Health Surveillance. So it would be useful to have some contact when questions arise.
Yeah, I'm glad to stay in touch. So I'll send my information to Angela, and then I think she can share it with you. And we also at the National Healthcare Institute, there is a group that is focusing on international collaboration. So if there is anything, perhaps there might be some support from both sides to each other to improve the healthcare decision making as a whole.
Yeah, very good. Thank you so much.
It's 4 hours ahead. Oh, sorry. I was going to say that it's 4 hours ahead in the Netherlands in comparison to Brazil. So,
Okay.
yeah, but go ahead. Sure. If you have a question, go ahead.
I like it when Mohammed called it's a solidarity system in which you are worried with the burden of disease, and the more severe the disease or the suffering of a person, the ceiling ratio is more tolerant. But how about the trade-off between burden in terms of severity of disease and burden of the number of people that are involved? Have the disease. Because
budget impact.
Yeah, I mean the number. Only rare people have a lot of suffering, but with the same amount, you could give a beneficial effect for more people, although there's more people doesn't have such a severe problem. So how do you do with this trade-off of individual suffering and the amount of people suffering?
For that, in the Netherlands, we try to illustrate that by performing a budget impact analysis, but that's only the impact it has on the financial consequences it has. So not necessarily the health issues. So we are trying to, so to answer your question, to see the implication of burden of disease in terms of financial consequences, we perform a budget impact analysis, which could be millions, which could be only 100,000 euros. And then we have a number of thresholds for that as well. And those thresholds actually only apply for whether or not a manufacturer should give us a full submission. So if it's above 10 million euros per year, we ask them a full submission, including a model, systematic reviews, and so on and so forth. If it's less than 10 million euros, we only ask a budget impact analysis because it's not too expensive. So in that sense, decision is being held, also looking at the consequences it has on the financial budget.
And there is a ceiling or of not approving based on the budget impact?
No, there is not. That's mainly only the ICER. But there is a certain other, let me think, a threshold, which is that the treatment should not, if it exceeds 50,000 euros per year per patient, we also need a full submission, but also that goes into a special procedure. And this is specifically the case for oncology treatments or gene therapies, which are really expensive, perhaps will never be cost effective, but we still need them to be part of the health insurance package. So they go into a separate part that I haven't shown you today. It follows somewhat the same steps, but it is a different side of it.
And do you have special flow for orphan drugs and orphan implants or equipments too?
Yeah, I haven't shown you that today as well, because I tried to keep it a little bit basic, but for a very expensive medication, it's called sluisprocedure. How do you pronounce,
Corridor procedure?
You know, when you're in a canal and you need to go up or down, you go into a thing,
Yeah.
you know? And so it's parked there, it's being reimbursed while the evaluation is going on, and eventually the ministry, so it automatically becomes part of the health insurance package.
Mm-hmm.
And then eventually, after it has been evaluated, and if it's cost effective, it stays. If it's not cost effective, it still needs to stay, because maybe patients don't have anything else, but negotiation takes place and all those kind of things.
Do you seek to take out things that are not cost effective or are not effective mainly?
Yes, that's, for instance, the example of Hanneke. So in the Netherlands, we also have this conditional approval, where automatically everything gets into the package in some cases. But if it's proven not to be effective anymore, it's going out of the package, yes.
So as soon as EMA gives the authorization for commercialization in the market, in the EU market, it goes into the package. And then you work to prove that it's not good and you take off.
Not always that route, but typically, yes, we first wait for EMA until the registration study and so on and so forth has been performed. And then it gets to us, and it's only for very expensive medication when it's becoming automatically part of the health insurance package. But when it's, for instance, for medication that we call extramural care, which is care outside of the walls of the hospital, those kinds are first being assessed before they enter the health insurance package. But very expensive and important treatments, they become part of the health insurance package right away.
Wow. Those oncologic drugs are very, very expensive.
Yes, and it's a big mess of all
the
little
chemo
pathways.
And but now we have radiopharmaceuticals. How do you label it? Is it medications or devices?
I don't know.
You never knew. For instance, PSMA in cancer prostate will, in prostate cancer will make a lot of pressure right now. I think even for many lines of treatment, lutetium is on trial right now. It's coming. It's expensive.
I can imagine, yes.
Yeah, I think
Wow.
the flexibility of our decision making will be tested more and more in the upcoming years.
It is difficult.
Yes. I think it's time to wrap up, Ayrton.
Yes, sure. So I'd like to thank you very much, and of course, all the attendees as well. And it's been a pleasure to have this session and also the course that it will continue until Friday. So thank you very much. And besides all the professors, I would like to thank Gisela as well, who is helping us very much. She is back in Brazil, and she's is a support, especially in the practice during the course. So thank you for your time and for sharing your experience with us.
Thank you, Ayrton, for having us virtually this year, but hopefully next year or year after we can actually come to Porto Alegre.
No, it will be a
And
pleasure.
São Paulo too.
And Sao Paulo, yes, yes.
São Paulo and Porto Alegre. In the Brasilia.
In Brasilia, please.
Yeah,
Yeah.
yeah, yeah, of course. The capital, please.
Yeah, why not?
Several
It's
places.
far away, but it is beautiful.
It's not far
Even
away.
though-
It's in the center of the country. It's equidistant
Yeah.
to all places.
Yes.
Even though
Thank you so much.
all of these places are not so nice as the beaches in the Northeast, isn't it? So,
Yeah. They are only
It is.
not only more cost effective, they are
So-
more effective.
Yeah,
Yes.
we have a center for training people there. Ayrton also participate the network. So the Fortaleza in Ceará is strong. Also, we can arrange if you have time. Probably July is the best. July and August is the best time for you. However, for us, it's vacation time. So we need to plan
Well.
ahead a year for June that the people are still there. So for this period of time in the year, it's beautiful and useful for us and for you too to know around here. See, Mohammed, we are 200 million here, more than almost 210 now. So it's not so easy than 17 millions only.
Yeah.
However, your cities are really astonishingly beautiful, and by the canal is and by the board also. It's very nice, very cared for, and we hope you know here, but also take pride of your own, because it's very beautiful too.
Thank you.
Thank you.
oh,
Thank you for all the
Oh.
interaction. Thank
Yes,
you.
have
so
a nice
much.
evening for you. I think it's almost bedtime for us. We have
yes, exactly.
years at
It's
this point in
past my
time,
bedtime. No.
so we cannot go out anymore.
Come on.
Okay.
Okay.
Thank you all for
Tomorrow.
the
Thank you all.
nice
Thank
discussion.
you.
Thank you.
Bye bye.
Bye bye.
Bye bye.
Good night.